All right, let's dive in and really master respiratory alkalosis. In this deep dive, we're going to break down absolutely everything you need to know about this key acid-base imbalance, from the basic science all the way to the clinical judgment you'll need for your exams and, more importantly, for your patients. Okay, picture this. You walk into your patient's room, and this is what you see. They're clearly anxious, they're breathing way too fast, and they tell you, my lips and my fingers feel tingly. Now, these aren't just random symptoms, right? These are classic textbook clues that are pointing you directly to one specific problem. And by the end of our time here, you'll be able to spot these signs from a mile away and know exactly what's happening. So, here's our game plan. We're going to tackle this from every angle. We'll start with the basics, what is it? Then we'll get into what causes it and how it messes with the body. After that, we'll decode those tricky lab results, and most importantly, we'll talk about what you are going to do about it, wrapping it all up with some can't-miss tips to help you crush your exams. Okay, first things first, let's start with the absolute fundamentals. Before we can even talk about the causes or what to do, we have to be crystal clear on what respiratory alkalosis actually is. So at its heart, respiratory alkalosis is all about breathing. It's that simple. When a patient hyperventilates, and that just means breathing too fast or too deep, they're literally blowing off too much carbon dioxide. And here's the absolute key to understanding this whole thing. In our bodies, CO₂ acts like an acid. So think about it. If you're blowing off too much acid, what's left? Your blood becomes more basic, or alkaline, and that makes the pH level shoot up. Think of it like a perfectly tuned balancing act. Normally, our lungs do this incredible job of keeping our blood pH right where it needs to be by managing how much CO₂ we breathe out. It's a precise process. But in respiratory alkalosis, that whole system gets thrown completely out of whack. The breathing speeds up, the CO₂ levels just plummet, and that delicate pH balance gets tipped way over to the alkaline side. If you're looking for one simple thing to burn into your brain, this is it. This is the entire concept in 3 simple steps. You blow off CO₂, which means you lose acid, and losing acid leads to alkalosis. It's a direct cause and effect chain that will seriously help you assess these situations in a snap. Okay, so we know hyperventilation is the direct cause, which leads to the next logical question. What's making the person hyperventilate in the first place? Figuring out these triggers is absolutely essential, not just for passing a test, but for being a sharp clinician. When you see someone hyperventilating, your brain probably jumps straight to anxiety or panic attack. And honestly, you'd be right a lot of the time. That's the #1 cause. But we have to think deeper. Could it be something in the lungs, like an early pulmonary embolism, where the body is just desperate for more oxygen? Or could it be a bigger systemic issue, like a fever or sepsis that's cranking up that respiratory rate? Listen up, because this is a huge NCLEX clue. This little trio of symptoms, anxiety, breathing super fast, and that classic tingling feeling, this is a clinical picture you are going to see over and over again in practice and on your exams. When you see this pattern, your brain should immediately scream respiratory alkalosis. Now that we've got the what and the why, let's really dig into the how. What is actually happening inside the body during respiratory alkalosis? And how does that whole process create the signs and symptoms we see at the bedside? Let's trace the physiological dominoes here one by one. It all starts with hyperventilation. The patient starts breathing off CO₂ way too fast. This makes their arterial CO₂ level, the PaCO₂, drop below the normal 35. This loss of acid immediately causes the blood's pH to spike above 7.45. Now, eventually, the kidneys will try to help out. They'll step in and start getting rid of bicarbonate to balance things out, but, and this is key, that's a much slower process. The symptoms you see are a direct result of this internal chaos. Sure, lightheadedness and dizziness are common, but the real telltale signs, the ones that get tested all the time, are the neuromuscular ones. That tingling, the numbness, the muscle twitching, those are your big diagnostic clues. And here's the cool science behind it. The high pH in the blood makes more calcium bind to proteins. This leaves less free or ionized calcium floating around for your nerves and muscles to use, which makes them super irritable and easy to excite. That's what causes the tingling. All right, let's get to the hard data. How do we prove it? How do we definitively diagnose respiratory alkalosis? Well, the answer is always in the arterial blood gas results. When you look at an ABG report, the numbers are telling you a story. In the early stage, what we call uncompensated, you're going to see a high pH and a low PaCO₂, but the bicarb will still be totally normal. This tells you the problem just started and the kidneys haven't had time to react yet. Now, if the problem sticks around, the kidneys kick into gear. They start dumping bicarb to try and pull that pH back down. So in a compensated state, you'll see both a low PaCO2 and a low bicarb level. If you're ever staring at an ABG panel and feeling a little overwhelmed, just remember this simple mnemonic, ROME. It stands for Respiratory Opposite Metabolic Equal. For any respiratory problem, the pH and the PaCO2 will always move in opposite directions. So for us, the pH goes up and the PaCO2 goes down. It's a foolproof trick that works every single time. Okay, so understanding the numbers is one thing, but what are we actually supposed to do about it? Let's shift gears from diagnosis to action. This is all about the nursing priorities when you've got a patient with respiratory alkalosis. Our primary goal here is really a two-parter. First, we have to help the patient slow their breathing down to stop them from blowing off all that CO2. But second, and this is just as critical, we have to figure out why they're hyperventilating and treat that root cause. Just fixing the ABG numbers without fixing the original problem, that's just a Band-Aid. So your immediate job is to assess and then intervene. You're going to be watching their respiratory rate like a hawk, checking their mental status, and seeing how anxious they are. Your actions should be all about creating a calm, safe, and reassuring space. And hey, a really important safety warning. That old trick of having someone breathe into a paper bag, we don't do that anymore. It's outdated and it can be super dangerous because it carries a real risk of causing severe hypoxia. Just don't do it. Now, this is a spot where a lot of students get tripped up, so let's clear it up right now, telling the difference between respiratory and metabolic alkalosis. Yeah, they both give you a high pH, but where they come from is totally different. With respiratory, the problem starts in the lungs. It's all about low CO2. With metabolic, the problem is in the kidneys or the GI system, leading to high bicarb. The key to telling them apart is looking at what started the problem and how the other body systems are trying to compensate. Whew, all right, we have covered a ton of ground. So now let's pull all these key pieces together. We're going to do a quick fire review to really lock in this knowledge and get you ready for your exams. Here are the absolute must-knows, the pearls you need to remember. What's the cause? Hyperventilation. What do the ABGs look like? High pH, low PaCO2. What's that key symptom? Tingling, and it's because of a shift in calcium. Which organ started the mess? The lungs. And what's your number one priority? You got it. Always, always, always treat the underlying cause. And to make it even easier to remember when you're under pressure, here are some super simple memory hooks. Fast breathing equals alkalosis. Blow off CO2, pH goes up. See tingles, think alkalosis. These simple phrases can be a total lifesaver on a tough exam. All right, let's put it all to the test with one last scenario. You've got an anxious patient, breathing fast, the ABGs come back, pH is 7.49, PaCO2 is 30, and bicarb is 24. That's a textbook case of uncompensated respiratory alkalosis. So what's your priority? What do you do first? The answer is B. Your immediate goal is to fix the hyperventilation. Encouraging slow, controlled breathing does exactly that. The other options are just plain wrong. They don't fix the root problem and could actually make things worse. And that right there is a perfect example of using your clinical judgment to pick the best, safest intervention.